we're going to inspect the musculature, check, as we have with the other body parts, inspection, palpation, range of motion. What we want to look for in terms of the scapula as a continuation really of the shoulder exam, so if you want to put it in there, is to check for any winging of the scapula, scapular weakness. Serratus anterior is controlled by the long thoracic nerve, which, okay, it's 5, 6, 7, 8.
5, 6, 7 bells of it.
Yeah.
So, interestingly, it's terminal. I'm giving you 6 months. Interestingly, keep doing that, as you can actually, so you can see that there's actually asymmetry here, right? You can see that this left, and as he's working, he's getting more, it's getting more and more prominent as he does more and more. I don't think he's got winging. I don't think he's got a serratus anterior or a neurologic problem. My impression is that he's actually got very weak scapular stabilizers here and much stronger stabilizers here. But you can see this is not actually too dissimilar from what winging starts to look like. So another example is just one may not be enough. You want to test something, right? When you're testing strength, you really want to kind of push people. When you do Faber's maneuver, you don't just have them, and we'll show you, they're not just going to get in the position. You're really going to apply a little bit of stress to that SI joint. Okay, let's take a step back. All right, let's see you bend over, touch your toes as best you can. Keep your knees straight, come back. So now you can extend your neck back, your low back, extend back towards me. Very good, nice job. You can stand straight up. I want to see you, oh yeah, when you're taking flexion, that's the key. Make sure that they don't flex their knees, right? Because here's what can happen. Right? There you've lost it again. So you're stabilizing by keeping their legs straight, and that's what you're kind of watching, okay? So you keep some extension. I want you to put your hands at your side. Now we want to test side bending. Well, you can try to explain side bending, or you can just say, can you take your hand, slide it down to your knee? There you go. Now, I almost lost him. You almost went into flexion. So you just want to make sure that they maintain either neutral or even a small bit of extension, because if you recall, you don't want to call it facet loading, but you can potentially stress the facet joints by putting extensor and lateral stress on them. So can you go back down and touch your knee for me? Excellent, nice job. Let's compare to the other side. Excellent, straight up. You can see in terms of inspection, checking symmetry, I don't see any skin folds that would be present on one side that may not be present on the other. Can I have your chest rotation? By keeping it, and now, see, I'm losing him again here, right? Because he's rotating everything down like a corkscrew. So what do you want to do? Now, can you rotate from side? There you go. Now I've isolated the lumbar spine, and I'm really just testing rotation, whether this causes pain. Now go to the other side, or if there's any sort of restricted range of motion. Okay. You can look straight ahead again. Remember Schober's test? We're going to do one of two things. You can either find the iliac crest. Those of you from residency remember what level is the iliac crest at?
4 or 5.
Excellent. So the crests bisect the level of 4 or 5, or if you want, you can find the PSIS. This is a test for mobility of the spine, right? Again, this can be related to ankylosing spondylitis. There's one of two ways. One can either find the iliac crest, which is at 4 to 5, and measure 5 centimeters below and 10 centimeters above, or the way that I've most often read about is finding the PSIS. Excuse me. Find his PSIS. Oh. Go to midline, make a mark. Measure 10 centimeters above, which would be and then 5 centimeters below, we're just going to make a mark. Excuse me. For display purposes, 1, 2, 3, 4, 5. Down here, we'll have the patient flex forward by. Oh, we want to keep that. Oh, actually, we'll have the patient flex forward all the way as much as you can. There you go. Very good. All right, you can stop. You're going to measure those 2 points, the most inferior and the most superior. You can come back up. And it should be greater than 20 degrees. If it's less than, then that indicates decreased motion, and you might want to look further for either a change in spondylosis or
No, when they flex, the range should increase. Whatever
Right.
the measurement should increase.
That's it, yeah, so if it's greater than 20 centimeters, right,
So you took like 10 and 5, so 15 was your mark.
is your baseline.
Is
It
your
should
baseline.
go by 5 centimeters.
Okay.
And if it's less than that, then it implies that they might have something like bamboo spine, ankylosing spondylitis, HLA disease. All right, you're done with it. Yeah, you can put that back on. Thank you. Sure.
Except for the groin.
Right, exactly. So let's do the sacroiliac joint. So sacroiliac joint, one thing remember is when you talk to the patient, can you show me where your pain is? Right there. That would be.
This is only for the demonstration that we see patients like this. Not in real life.
That would
We're
be.
going to see anything else but that.
That would be the right. I told you. That would be the Fortin finger test. Fortin was a surgeon who that was first named after. What I like to do is find the lateral borders of the sacrum and kind of walk my fingers up. You're going to come to at a very identifiable spot where you're going to feel sort of somewhat of an articulation between the sacrum and the iliacus. You ask the patient, is that where you're having any of your pain? Right. I'm going to have you do the Stork test, which is flex your hip up. We'll compare side to side. That's right.
So what are you looking for when you do that?
What we're testing for, that's one. Let's do the left side. What I'm doing is I'm checking, put that down, for any restriction in the SI joint, which means...
In terms of how it moves.
In terms of its motion.
Okay.
Because what you should feel is that you should actually feel it being more posterior, because you're going to have posterior rotation.
So it should tilt back.
Correct.
Okay.
And you're going to feel more under your finger on the side, on the ipsilateral side. If you don't, that implies some restricted motion. That may not imply sacroiliitis, but this may be something that's amenable to physical therapy or mobilization of the joint.
Mm-hmm.
And you can feel it, we'll feel it on other people. Okay, let's get back down. Let's try some more provocative maneuvers for the sacroiliac joint.